Welcome to the deep dive. Today we're tackling something really practical, especially for those of you heading into clinical roles. It's about preventing complications, specifically contrast-associated acute kidney injury, or AKI, after cardiac catheterization.
Right. A big risk. We learn about prevention in studies, under ideal conditions.
Exactly. But what happens after the study ends? When the support structure is gone, does everything just go back to how it was? That's what we're digging into.
Yeah, it's a critical question. We're looking at a follow-up to the IMPROVE AKI trial, which is published in the Journal of the American Heart Association. It asks, basically, did the good results stick?
And our mission here is to unpack that. Did those initial wins last? And maybe more importantly, what does that mean for you, the medical students and residents listening who will be involved in these procedures very soon?
Precisely. So let's set the scene a bit. The original trial, IMPROVE AKI.
Yeah, that ran from late 2019 to early 2021, 20 VA sites.
That's the one. They tested team-based coaching. They called it a virtual learning collaborative, or VLC, and also automated surveillance reporting dashboards, ASR. Sometimes alone, sometimes together.
All aiming to cut down AKI after cath procedures. And those initial results, they were pretty good, weren't they?
Oh, yeah. Very encouraging. In that active phase, the sites using both the coaching and the dashboard, they saw a 46% drop in the odds of AKI.
Wow, 46%. That's huge. Almost cutting the risk in half.
It really is. But, like we said, the real test, is sustainability. Does it last?
Which brings us right to this deep dive, the sustainability phase. So after the active coaching stopped, they watched these sites for another 18 months, April 21 to September 22.
That's right. The coaching calls ended. But interestingly, those ASR dashboards, they were still accessible if sites wanted to use them.
Okay. So it wasn't like everything was just switched off completely for everyone. It was more about removing the active push from the researchers.
Exactly. They were observing what happened naturally. Could those better habits, those processes, actually stick without the intensive support?
So the study design then for this phase was this passively monitored 2x2 factorial thing again, following the same kinds of patients.
Yep. Adults having diagnostic angiography or PCI, but not those already on chronic dialysis, keeping it consistent to see if the earlier effects lasted in that same population.
And they were still looking primarily at AKI within 7 days using the standard KDI-GO criteria, increase in creatinine or needing dialysis.
Correct. That was the main outcome. They pulled the data from electronic health records, which is, essential for this kind of large-scale follow-up.
But it wasn't just numbers, right? I saw they did qualitative work too, interviews and surveys.
Absolutely crucial. They talked to the staffs, surveyed them to get the why behind the numbers, what helped things stick, what got in the way. You really need that ground-level perspective.
Okay, so the big question, especially for our listeners heading into practice, did it last? Did those initial impressive results hold up in that 18-month sustainability phase?
Well, here's what's really interesting. The overall AKI rate during this sustainability period, it was about 11%, which is very similar to the rate during the active intervention.
Really? So it didn't just bounce back up?
Not overall, no. And even in the higher risk patients, those with chronic kidney disease, the AKI rate was around 17% in this phase. Again, pretty close to the 18% seen during the active phase.
Okay, that's genuinely encouraging right off the bat. Suggests the initial push had some lasting impact. But what about the different groups? Did that combination, the VLC plus ASR, still outperform the others? Because that seemed like the most intensive intervention.
It did. That's one of the clearest findings. The sites that had both the coaching and the dashboard initially, they continued to have significantly lower AKI rates compared to the sites that only got technical assistance.
How much lower?
The adjusted odds ratio was 0.60. So that translates to a sustained 40% reduction in the odds of AKI for that VLC plus ASR group, even during this later phase after the coaching stopped.
Wow, a 40% sustained reduction. That's really something. It suggests that initial investment, even if it's resource intensive, can pay off long term.
It certainly points that way. And when they look at the whole picture, both phases combined, so the full 36 months.
Right, the entire study period.
Yeah, the VLC plus ASR combo was linked to a 43% reduction in the odds of 7-day AKI compared to just technical assistance alone. That worked out to about a 5% absolute drop in the adjusted AKI rate for those sites.
A solid 5% difference maintained over 3 years. And similar findings for 30-day AKI, too.
Similar positive trends, yes. It seems quite consistent.
Okay, that's compelling for that combined approach. But you mentioned the overall rate was similar between phases. The study also noted, I think, that AKI rates were actually a tiny bit lower across all the groups in the sustainability phase compared to the active phase, like 1% lower.
Yeah, that was an interesting little finding.
Any idea why that might be? Maybe just a general rising tide lifts all boats kind of thing? Increased awareness everywhere?
That's definitely plausible. I mean, the trial itself, even for the control groups, probably raised awareness. And remember, all sites got that AKI prevention toolkit right at the beginning.
Ah, right. The toolkit with the standardized orders, the hydration advice, limiting contrast.
Exactly. So maybe that baseline level of information and focus nudged everyone towards slightly better practices over time, regardless of their specific intervention group.
That makes sense. This study did say lots of sites adopted those strategies during the active phase, standard orders, hydration protocols, contrast limits. Maybe that initial implementation just created a new baseline.
I think that's a very likely factor, and it leads perfectly into those qualitative findings,
Mm.
the insights from the staff, because that's where you see the real-world stuff, what helped keep those strategies going and what made it hard.
Okay, let's talk barriers first. What were the big roadblocks people mentioned?
Well, no huge surprise here maybe, but staff turnover and just limited staffing in general, that came up again and again.
Yeah, that's a constant battle in healthcare, isn't it? Hard to keep protocols consistent when the team keeps changing.
Absolutely. It puts huge pressure on training and just maintaining standards. Another big one was organizational culture. Things like, not getting full buy-in from everyone or just resistance to changing the way things have always been
Good
done.
inertia.
Yeah.
Yeah. Implementing change isn't just about having a good idea. It's about the people, the culture. What else?
They also mentioned practical difficulties, like actually building and using standardized order sets effectively within their EHR systems.
Ah, the tech integration challenge.
Right, and coordinating between departments, making sure everyone's on the same page, and sometimes patient factors too, like difficulties getting follow-up creatinine levels.
So a mix of people, process, and system issues. Okay, on the positive side, what helped things stick? What were the facilitators?
Top of the list. Strong buy-in from staff. And critically, having local champions, those enthusiastic individuals on the ground who really pushed for it and kept the momentum going.
Yeah, you always need those champions, don't you? What else worked?
High-functioning teams. Teams where nurses were really involved, communication was good. That made a big difference. Also, good coordination between departments like radiology or pharmacy.
Makes sense. Breaking down silos.
Definitely. And practically speaking, having those standardized order sets permanently built into the workflow helped a lot. And finally, just maintaining awareness, keeping AKI prevention top of mind. And for the sites that had it, continuing to look at their ASR data helped reinforce things.
This is all such valuable stuff, especially for you listening at the students and residents. Thinking about your future roles, what are the key takeaways you should really hold on to from this study?
Well, first, it's a powerful reminder that evidence-based interventions really do work. These AKI prevention strategies, when implemented well, make a real, lasting difference to patient outcomes.
So the things you're learning about evidence-based practice, they matter long-term.
Absolutely. And it shows that even if an initial intervention seems resource-heavy, like that coaching element, it can lead to durable benefits. So it might be worth advocating for those kinds of comprehensive approaches when you see an opportunity.
And importantly, understanding those barriers we talked about, the staffing, the culture, the workflows, knowing those are common problems can help you anticipate them.
Exactly. If you know what to look out for, you're better prepared to try and address it in your own teams later on. You could be part of the solution.
And likewise, knowing what helps the champions, the teamwork, the data, you can actively try to foster those things.
Precisely. Promote teamwork, maybe even be a champion for a particular practice. Encourage the use of data. It reinforces that combination of education and collaboration plus data feedback. That seems to be a winning formula for sustained improvement.
And while this was about AKI and cath labs, these principles, identifying barriers, leveraging facilitators, the importance of teamwork and data, they apply everywhere in medicine, right?
Oh, absolutely. These are core principles of quality improvement and implementation science, relevant no matter what field you go into.
Okay, so let's try and boil it down. The key takeaway message here is
That team-based coaching combined with data surveillance can lead to real sustained reductions in AKI risk after cardiac cath, even after the active support winds down. The initial investment pays off.
right. And for you, our listeners, this offers really concrete insights into making quality improvements stick. It's not just about the initial push, it's about understanding the human factors, the system factors that keep good practices going.
You need to pay attention to those things to make improvements last. Think about how you personally can contribute to that culture of sustained quality.
So here's something to really chew on as you move forward in your training and careers. We see here that relatively simple things, standard orders, hydration, watch and contrast dose, can have a significant and lasting impact. So what role can you play, even as a trainee right now, in championing these kinds of evidence-based practices? How can you help reinforce them day to day within your teams?
And thinking ahead, what specific strategies could you use to try and overcome those common barriers like staff turnover or resistance to change in your future practice? How can you help build systems that support sustainable quality?
Lots to think about there. And if you want to get deeper into the details,
Yeah, the full article's in the Journal of the American Heart Association. And maybe look into implementation science literature more broadly. Understanding how to make change happen and stick is it's a really valuable skill set for any physician.
definitely something that will serve you well throughout your entire career.